resources. Well, some are, but not all. So 77 million Americans have limited health literacy. It's associated, as I mentioned, we alluded to it in that first question, increased use of emergency departments, more frequent hospitalizations, especially in certain groups that were studied, for example, asthmatics, higher hemoglobin A1C levels in diabetics with low health literacy, and greater all-cause mortality. Studies have shown this. And it's kind of common sense, right? If you can't understand the instructions and you're not taking your medications right, you're going to end up in the ER or the hospital or worse. So we have another pretest question here to quiz your knowledge. Get your little remotes out again. Which of the following statements is true regarding health literacy assessment? Okay, so now we're looking for which one of these is true. Patients generally conceal their illiteracy or language deficits from providers. Number 2, formal assessment tools must be used to accurately assess health literacy. Number 3, the physician or primary care provider should administer any assessment tool. Or number 4, the TOEFL instrument, it's a specific one, is called the Test of Functional Health Literacy in Adults, maybe you're familiar with it, can be administered quickly, usually less than 1 minute. And then number 5 is unsure. So let's see what we think. I know it's early in the morning, but we got to get your mental juices flowing here. Okay, let's see what we got. So yeah, number 1 is actually the one true statement there. But again, only about 60% of you, so we want to get that number up. The rest of it, we don't need to use formal assessment tools. It doesn't have to be me as the doctor that is doing any kind of assessment. And then that particular instrument, if you're familiar with it, it actually takes about 10 minutes or more to administer. So it's not one that's really useful in primary care practices, but it's used a lot in research. So let's see if we can go forward here. All right. Some of the challenges are that patients tend to hide this from us. It's usually a matter of shame or feeling embarrassed. If somebody can't read, they don't necessarily want to announce that to the world, or if somebody didn't have a chance to get an education, didn't graduate from high school, they're not going to be necessarily proud of that. So patients usually don't tell us outright, but there's a lot of clues, and I'm sure you've all seen these things. People will say, I can't fill out the form, I forgot my glasses, or let me get somebody to read it for me. They'll say that. Or the famous, is that the white pill or the pink one? People don't have any idea what really they're taking or why they're taking it. Obviously, we don't expect our patients to become medical students and be able to know the brand name and the generic name of medication. That's unreasonable. But at least they should know, okay, this is the one I take for my bladder at night, and these ones I take for blood pressure. They should have some basic knowledge. If we're putting this chemical in our body, we should know what it is. Sometimes patients will just kind of seem a little aloof or anxious or unable to focus during the interview, and then they'll have difficulty in describing their symptoms. I'm in Southern California, and I take care of a lot of immigrant Mexican or Latino patients, and it is really difficult sometimes for them to convey, what is bothering them. A common thing maybe you see here in your population, if they're talking about back pain, they won't necessarily say, it's my back hurting. They'll say, well, I feel air on my kidneys, aire en los riñones, right? And you say, what does that mean, air on the kidneys? Well, when you explore and ask, you realize they're talking about back pain. So people with low health literacy or cultural differences will sometimes have difficulty conveying that. All right, another question. We're keeping you on your toes since it's early. Get your remotes out. Which of the following is not a risk factor for low health literacy? So which of these is not associated with low health literacy? Number 1, polypharmacy with greater than 4 medications taken by a patient. Number 2, age greater than 65. 3, limited English proficiency. 4, less than a high school education. 5, unsure. Good. I can see the coffee kicking in now. People are getting sharper. We're going to get 80% at least on this one. Oh, maybe not. I'm misreading. I'm not applying health literacy skills. The one that's not a risk factor is actually polypharmacy. You can have some patients that are quite sophisticated and quite knowledgeable, but they require a lot of medications. That's not necessarily something that's correlated. But the rest of them are. So 1 is the correct answer. Half of you got that correct. As I said, elderly or advanced age is a risk factor. So why is this important? And as I said, I've been to a lot of health literacy lectures, and I'm sure some of you have. And one of the problems that I always have with it is like, this takes time, and nobody pays for this, and it's sort of on top of everything else that we're doing. But we have to face the reality, and one of the things that we know demographically in our country is that there's this silver tsunami, right? Have you heard that term? That the baby boomers are advancing, and that aging or graying of the society is happening because we have this big bulge of population that is getting into the 60s and 70s. So we're going to be hit with a tsunami. We're going to be hit with an epidemic of elders, of people joining on Medicare, and that is associated with a lower health literacy, as I mentioned, because of cognitive deficits or just because of unfamiliarity with the changes in the world, changes in technology. Low education level, I think that's pretty simple and straightforward. If somebody doesn't have good language skills and they don't have good math skills and they didn't get much formal schooling, they're going to have trouble understanding medical concepts. Of course, cultural issues. If somebody has limited English on the one hand, and then, as I mentioned, cultural differences where their concept of what is a symptom or what is a medical condition is different, we're going to have trouble getting that person to understand. And then poverty and socioeconomic status. Another reason that this is so important to look for this in our practice and understand your own patients and then to apply interventions is because, as you all know, healthcare is changing rapidly, and we are moving from a system that basically rewarded us for episodic face-to-face encounters, not continuous, basically like fee for service, right? That's how traditionally doctors were paid, fee for service. We weren't necessarily held accountable for the outcome. We try to do a good job the best we can, but nobody was saying, well, we're not going to pay you if that person doesn't get better. Well, with all of this healthcare reform, the Accountable Care Act, Obamacare, whatever you want to call it, there's changes in medicine, and we are moving to more of a continuous chronic disease management model, which is not based on face-to-face episodic encounters, but it's based on taking care of a population of patients and keeping people out of the hospital and keeping them out of the emergency room and catching their illnesses early. And so we're not going to be able to do that if we don't address these health literacy concerns. Let's see, we can go forward here. Sometimes we'll mislabel patients who have low health literacy, and this is another way to kind of identify them in your practice. They're the people that say, oh, that guy's a poor historian. He never makes any sense, and we can't get information out of him. Or, oh, she's non-compliant. She never does anything that we tell her to do. Or he's irresponsible. She's lazy, unwilling to take responsibility for their own health care. Certainly there are patients like this. I mean, don't get me wrong. There's many people who are just irresponsible. They're flaky. They have mental health issues. Maybe they have some psychological diagnoses that impair their ability. But by and large, a lot of patients who fall into these labels are actually people who just have low health literacy. And if we could identify that and address it, then maybe they would jump out of these categories and become a compliant patient or become a responsible patient. As I mentioned, there's a lot of cost of poor health literacy, and people are looking at that now. In my hospital in Rancho Mirage, we're going to get penalized if people get readmitted. They basically, Medicare is saying, we're not going to pay if the patient gets readmitted. That's on you guys. So the hospital is trying to get us all together to become more of like an accountable care organization and to bundle. Have you heard about bundling? That's another very popular thing that's happening. And if you do any hospital work or even any post-hospital work, like taking care of nursing home patients after a hip operation or after a stroke, those things are going to be bundled now, where Medicare is going to give one payment, and it's going to reflect what everybody does, and it's not going to be fee-for-service anymore. So if you have patients with poor health literacy, it's not only is it going to cost the system because of longer hospitalizations or more emergency room, it might actually cost us. It's going to be possibly money out of our own pocket or out of the group's pocket because of these indicators. All right, so how do we quickly assess for this? There are some formal tools that can be used. I'm not necessarily saying that you need to incorporate one of these, but I'll go over them briefly. The simplest one is called the newest vital sign, and I bet you all of you have seen it, but maybe haven't used it. There's a more complicated ones that are called the REALM, the Rapid Estimate of Adult Literacy. That's a list of words. It's 66 words, and you try to get the patient to just pronounce them. And if they can pronounce the words and read them, that's correlated with better health literacy. The TOEFL, I mentioned that earlier, that takes at least 10 minutes. That one is a couple of paragraphs with their medical situations. Like one of them is very similar to instructions for a gastro procedure, like if you hand the patient instructions for a colonoscopy. But then it has all these words missing, and you ask the patient to try to fill in the words. And then there's another one that's sort of like an informed consent, and you ask the patient to fill in words. This has been studied and validated, and it's found that if people can fill in the words, guess what the right answer is, then they're going to have a higher health literacy. But they can be administered by the staff. It doesn't have to be me that does it. The newest vital sign, as I mentioned, that only takes about 3 minutes, and it's essentially a nutrition label. It's a nutrition label like you would see on the side of an ice cream carton. And you have that and you show that to the patient, or the medical assistant shows it to the patient, the clerical staff can show it to the patient, and then they have to answer 6 questions about it. And the more answers they get correct, that's correlated with a higher health literacy. The more they get wrong, then that's low health literacy. Some of the questions are pretty simple, like the first one. I don't know if you can read it, but basically it says, if you eat the entire container, how many calories will you get? And of course, when you look over to the left, you see, well, this particular container has 4 servings. It's not just 1 serving, it's 4. So if the calories per serving are 250, then we have to make that mental calculation. 4 times 250 is 1,000. But there's other questions that are harder. And basically, we're trying to see, do these patients have a concept of what nutrition is, and that is generalizable to their health literacy. So that takes about 3 minutes. And if somebody's on a 0 to 1, then you know they have very little understanding of anything that you're going to tell them. If they have a 6, they're pretty sophisticated. So what do we do to address it? Well, one of the things and I think we all try this, we're all primary care doctors pretty much, or primary care providers in this room, and we generally do a good job of simplifying our talk. You know, we try to eliminate jargon, keep the points relatively short, prioritize so that we say, well, these are the 3 things that we talked about today. But we should try to confirm that patients understand us, and we should use visual aids if possible. I call it universal precautions. You could have somebody who's an attorney in your exam room, so you assume that they're very smart, knowledgeable, educated. You could have somebody who's a farm worker. But you should still say, well, this is a medical encounter. It's been shown that people like simpler language. It's been shown that people want simpler English on their paperwork, and so we need to adjust accordingly. I'll give you an example. I just saw a consult come back about 3 days ago from a cardiologist. It's a patient that we share, and the patient is 82. He's a retired attorney, so he's a very smart guy, and he doesn't have dementia. He doesn't have, at least a measurable cognitive impairment. So he saw the cardiologist in May, and the cardiologist said, I want you to start digoxin because you're still having palpitations and you're still having irregular heartbeats, it shows up on your Holter. And this guy, because he's 82, he's already tried beta blockers. He couldn't tolerate those. He's already been on amiodarone. He's on a calcium channel blocker now. So he's kind of covered all the bases. So the cardiologist said, I want you to take digoxin for your palpitations. So then they saw him back a month later. Guess what? He hadn't taken it. And they said, how could you be not taking it? He says, well, I understood that I was supposed to take it for palpitations. I haven't had any palpitations, you know. So imagine if somebody was taking digoxin as needed. I mean, that could be potentially dangerous, right? And this is an attorney. This is a sophisticated, learned man. So I'm telling you, this happens all the time. And I'm sure as you think about your own practice, you're like, yeah, this is something that does happen. Okay, another pre-test question here. Which of the following is not true regarding tools to improve patient understanding? So I've talked about some formal assessments. I'm going to be talking about some informal assessments. So which is not true? Number one, there is no one-size-fits-all approach to improve patient understanding. Number two, utilization of tools to address health literacy necessarily increases the length of the visit. Number three, ideally, multiple approaches should be used, including written and multimedia, if possible. Number four, compliance and patient satisfaction can be improved by using tools like the teach-back technique. And five is unsure. So let's see what you get on this one. I'm not going to jinx you by making any predictions this time. Okay, so number two, yeah, that is correct. This is the best we've done so far. Almost 80% of you got this correct. It does not necessarily lengthen our visit because, as I mentioned, some of these formal tools, you can have the staff delegate it. And then, like I said with my attorney patient, they wasted a whole nother visit because the patient hadn't done what the cardiologist wanted to. So that was like a complete waste of time. You're actually using more time than necessary. And if they had used maybe the teach-back technique, this wouldn't have happened. So clear communication. We want to simplify the level of language that we use. Eliminate the jargon if possible. Don't use technical terms. Use terms that the patient can understand. We call it living room language. Maybe you've heard of that, living room language. Just how you would talk to somebody at your home. And then you can employ techniques, and I'm going to go over the speak, teach back, and learn so that there's something that will resonate with you. We're trying to eliminate this, gobbledygook, right? And a lot of patients, when they come to a doctor and they leave, this is what they hear or see. It's just a mess, gobbledygook. They can't understand it. So let me just go over the teach back technique. Very, very simple. It's also called the tell me technique. Maybe you've heard that, tell me method. Very simple. You ask the patient to repeat in their own words what you have taught them or instructed them to do. So if that cardiologist had done this, they would have taken my gentleman and said, all right, I want to make sure that I explain this correctly. So, what are we going to do about your palpitations? And then my patient would have said, well, you've given me this medicine to take as needed. And the cardiologist said, no, not as needed, every day. It's very important to take this every day. That's all that the teach-back technique is saying, okay, this is what we've covered. What did I say was the cause of your high blood sugar? And they'll say, well, you say I have diabetes, or what did I say was the cause of your insomnia? Well, you say I have anxiety, What are we going to do about it? You want me to take this medication at bedtime, or whatever it is. That's all it is. It doesn't add a lot of time to it. We call that the teach-back technique. The Ask Me 3, maybe some of you are familiar with this. I mentioned it earlier. There's something called the National Patient Safety Foundation. I actually heard about this from my malpractice carrier, because about every 2 years I get a visit from the doctor's company. That's who I use. It's my malpractice liability. And they want to come to the office and just see how we do things and see if they can help me minimize my risk of a lawsuit, right? I don't want to get a medical malpractice lawsuit. So they said, you should incorporate this. This was a movement that was originally for patients. It was a patient education campaign. And they were saying, you patients should always ask your doctor, what is my main problem? And what do I need to do about it? And why is it important for me to do this? They studied this, and they found out that if people are engaged and they ask these questions, then they're more likely to follow through with what we have them do. Well, what I did is I have an electronic health record that has very customizable documents. I can basically create a document very easily that incorporates, it just takes things from the note. So I don't do any extra work. I just hit a button. And I did this Ask Me 3. So in all of my progress notes and under the plan, I'll say, the main problem today was diabetes not controlled, and we will increase the metformin, and then, because the metformin will control the sugars and decrease risk of complications. Simple, like that. And it makes my documentation better on my progress note, but then when I print it out and hand it to the patient, it'll say, the way it comes out on the paper, it says, what is my main problem? Diabetes not controlled. What do I need to do? Increase the metformin to 1,000 twice a day, or whatever it is. Why is it important? To prevent complications. And they take that with them. So I've told them verbally, and then they take it with them. Obviously, it might be easier for some of you to incorporate this than others, but it's something that can be very automatic with these new electronic health records. Okay, all of the following are benefits of teach-back technique, except, number one, diabetic patients are more likely to achieve hemoglobin A1C targets. Number two, overweight patients are much more likely to lose greater than 10% body weight. Number three, in glaucoma patients, doctors were better able to detect medication non-adherence. Number four, increased satisfaction in migraine patients. Or number five, unsure. So get your remotes out. Okay, so let's see what we got here. So actually, the correct answer on this one is number two, because at least in the available research, we've never been able to see that just using the teach-back technique is going to help people lose weight. Overweight and obesity is one of the most challenging problems that we deal with every day. But all these other things, the hemoglobin A1C in diabetics, the teach-back technique has been shown to improve that. In glaucoma patients, they took their drops, the eye drops, the way they were supposed to. Because sometimes that can be very confusing, the eye drops for glaucoma. You take this one every 6 hours, and you take this one twice a day, but then after 3 days, you're going to take it can get complicated. So when they did the teach-back, they found that the glaucoma patients did better. And then in migraine patients, they found they had increased satisfaction with their doctor. Like they felt like their doctor was listening to them and taking their feelings into account. So there's some compelling evidence of why we should do this. All right, we're going to do a case right now. I'd like to invite, this is our actress, and we're going to do a couple of role plays here to demonstrate what we're talking, okay? This is Princess Clark, that's her real name, but right now she's going to be Maria G, all right? Maria G, and I have a description of Maria G up at the top. 72-year-old Latina female, Mexican-American in this case. She's bilingual in Spanish and English. She's a widow. She lost her husband. And her appointment is in for insomnia. Okay, she's having insomnia. But she has a history of diabetes, hypertension. She had an MI and had to have a stent 2 years ago. She has reflux also and irritable bowel syndrome. I'm sure that you all have some 72-year-old patients that have very similar profiles. She's taking metformin, metoprolol, lisinopril, omeprazole, dicyclamine as needed because of her irritable bowel, and then a baby aspirin every day. So, like I said, we're going to do a little role play here and sort of model a visit. All right, have a seat right here. So I'm seeing for appointment. Well, hello, Miss G. It's good to see you again. I know that this is an appointment for a routine visit, but is there anything specific that's bothering you today?
Well, I think I need something for sleep. I'm really having trouble.
What do you mean?
Oh, I mean I can't sleep, and even if I do, I wake up, and then I can't go back to sleep. I even tried. I've even tried. Where is it? Oh, I've even tried this, and it doesn't help. it just makes me dizzy, and I feel tired, and I feel nervous.
Yeah, you seem upset. Are you worried or anxious about anything or stressed?
Yeah, my son is really giving me a lot of headaches. He's going through a divorce. He's moved in with me, and he's drinking way too much, and I just don't know.
Yeah, that's terrible. Have you noticed that you've been sad and down and crying a lot?
Yeah, I've been feeling bad. I've been feeling bad for my son and my grandchildren. I'm feeling bad. Me and my husband, we didn't have the best marriage, but we tried to raise our children right.
Do you have noticed any changes in your appetite?
Yeah, food just doesn't taste the same. I just don't have the appetite. And my slow stomach, my belly pain, it's all starting to act up again.
Is there anything that makes you feel better, like talking to family or friends or going to church?
I don't have the energy for that. I haven't gone to church because I feel like things are hopeless. It's not the same. It's not the same.
Miss G, you have what we call a chemical imbalance, a neurotransmitter imbalance in your brain. And we need to address that, and I'm going to give you a medication. It's called Paxil or paroxetine. Maybe you've heard of it. It's going to help you sleep better. It's going to make you feel better. It's going to increase your energy. And it's going to help with your IBS symptoms as well. So I want you to do some lab tests because I want to make sure that your thyroid's not the problem, your TSH. I'm going to check your glucose, hemoglobin A1C, those kind of things. And then I want to see you back in 3 weeks, okay?
Okay.
So, you probably observed some things about that interaction, and, I think, like I said, you probably can relate. You've all been in this situation. So 3 weeks later, I'm going to see her again. Well, Miss G, I'm glad to see you again. How are you doing?
Okay, I guess.
Well, how's that medication working?
I didn't take it.
What do you mean? I gave you that medication to help you feel better. I wrote your prescription last time.
Well, I asked the pharmacist, and then he said, I asked the pharmacist, he said it was for mental health and not for my insomnia. And he said, if I start to take it, I said, am I going to get addicted to it? And he said, well, if I start to take it, I should continue taking it unless I get instructions from you.
Well, where did you do those labs that I asked you? I wanted you to get some lab tests done.
Oh, I didn't do the lab test because I didn't take the medicine. I didn't think I needed to.
All right, does that look like a familiar scenario? I mentioned my attorney a minute ago, but these things happen, right? You see people back and they haven't done what you asked them to do, and they haven't done the lab test, they haven't taken the medications. So what we're going to do is we're going to replay it, now that we've been to this lecture on health literacy, and so we know that we can do things differently. And so, this is what you'll be doing on Monday morning with a patient maybe like this. And then, again, some clues. When we look about her background, she's Mexican-American, she's bilingual, so we can probably guess maybe she's got some, English issues a little bit, maybe some cultural issues that we haven't really uncovered. And then she's older, and so she's probably not going to be understanding as well. All right, so we're going to go again, and this time we're going to change a few things. Hello, Ms. G. It's good to see you again. I know you're here for a routine appointment, but is there anything specific that I can help you with?
Yeah, I think I need something for sleep. I've really been having a lot of trouble.
What do you mean?
I mean, I can't sleep, and even if I do, I wake up, and then I can't sleep. And I even tried this, and you see, it doesn't help. It makes me feel dizzy, and I feel tired. I feel nervous.
Are you worried about something?
Yeah, my son, he's giving me a lot of headaches. He's going through a divorce, and he's drinking way too much. He moved in with me because his wife kicked him out.
That is terrible. I mean, you look very upset. Have you been having sadness, or do you feel down? Have you been crying a lot?
Yeah, I feel bad for my son and for my grandchildren. I don't know why this is happening to him. I mean, me and my husband, we didn't have the best marriage, but we tried to raise our children right.
It really seems like you have something that we call depression. Have you noticed any changes in your appetite?
Oh, I don't feel like hungry anymore, and food, it just doesn't taste the same. And my slow stomach, my belly pain, it's all starting to act up again, Doc.
Yeah. If we have depression, sometimes we do things to try to make us feel better. Have you noticed that you feel better if you're talking to family or friends or going to church?
Oh, I don't have energy for that. I haven't gone to church because I feel like all things are hopeless, and it's not the same. It's not the same.
Earlier you used this word, nervios, I think, nerviosa. Can you tell me what that means?
Oh, nervous. I feel tired. I feel weak. I feel so worried. I just can't rest. I just feel so worried.
Yeah, I can tell that you're really down and you're not yourself. And we call this a condition that's called depression. That's the word that we use. But it's an illness. It's like your diabetes. It's like your coronary artery disease, your heart disease. And depression can make you feel sick. It can cause symptoms that make you feel physically sick. It can cause insomnia. It can make your pain worse. It can make you more tired. It can make you anxious. This word that you use, nervios, that I'm interpreting that as anxious, nervousness, anxiety. So there's a medicine, it's called Paxil or paroxetine, and you take it every day, and it helps you to treat this illness that we call depression. So I want you to start with a low dose so we don't cause any side effects, and you're going to take it every day, and then I think that you're going to start feeling better, but it's going to take about 3 weeks. I also want you to do some blood tests because I want to make sure that we're not missing something else. So can you do some blood tests maybe tomorrow or something?
Yeah, I can take the test. And you say my poor sleep is caused by depression?
Yeah, it's a very, very common thing. Depression is extremely common, especially in people with diabetes and people with heart disease. And it causes the symptoms just like you're saying. And insomnia is a very, very common thing, not being able to sleep. So I want to make sure that I explain things well to you. So what did I say is the cause of your sleep problems?
You say I have depression and I can't sleep because of it.
Right. And so what are we going to do about it?
Well, you want me to start this medication. I think you call it Boxo, and Boxy's gonna help me with my slow sleep and my depression. Is that right?
Correct. Yeah, that's exactly. It's called Paxil, but it's a little pill, and I want you to take half every day in the evening because it's going to help you to sleep. And then I want you to get some blood tests, and I want you to get some blood tests before you come back next time because I want to check some other things, all right? And then we're going to see you back in 3 weeks.
Well, you want me to take a half a pill every night, and no, this medicine is safety, right? It won't make me anxious, and I won't become addicted to it.
No. You cannot get addicted to this medication. It's very safe. We've been using it for many, many years.
And it won't make me loco or crazy, right?
No, it will not make you crazy. No, it'll actually help you. I think it'll help you. But I want to get you started on it, and then we'll see you back in 3 weeks, okay?
Okay, thanks, Doc. I'll go.
Okay, so obviously that's probably a little bit over the top, but we made a difference, right? A different approach. And see how I just wove in that ask me, or the teach back technique, with her. And I just slowed it down and explained it. I didn't use the chemical neurotransmitter imbalance thing because, that sounds good to us, but it really doesn't help patients very much. All right, so 3 weeks later, she comes back. Miss G, how are you doing? It's good to see you again.
Hi, I think I feel good. I think it's working.
Yeah, you've been taking the medication?
Yeah, I'm sleeping a lot better.
Yeah, that's great. And I got your labs back. Thank you for doing that. Your diabetes is actually under pretty good control. I'm glad you're doing better.
Okay, thank you.
All right, so one example, and like I said, we did this because sometimes, you hear it, but then you say, well, how can I really apply it? So we're going to do a little costume change for Princess here. Thank you so much. So I've mentioned a couple of mnemonics that I think are helpful, as we think about this problem and we try to assess it in our patients. Oops. Did we do this one already? Yeah, okay. So there's something called the speak mnemonic. And this is a really good article. It was published in the journal Geriatrics in 2006. If you have a particular interest in this whole topic, maybe we work in a very large multi-specialty group and you're sort of the communications person, or maybe you work in a public health setting, I really recommend this because it encapsulates all of these concepts of health literacy in a very, very quick and easy read. But the speak mnemonic, the S stands for speech. And I guarantee you, all of us who are experienced clinicians, experienced providers in this room, we're doing this, maybe not formally, maybe we haven't seen this mnemonic, but we're kind of doing this in the back of our mind every time we see a patient, because it's very intuitive and we always kind of size somebody up, right? When we're first meeting them, we're trying to gauge, okay, where are they coming from, what's their education level, but this formalizes it. So the S is for speech, which is basic language. Does this person speak English? Do they understand English? Do they have limited English proficiency? Am I going to be able to really get through to this person? So that's the S. The P is for perception, and this is very literal perception, meaning does this person have a hearing impairment? Does this person have a visual impairment? Does this person have a cognitive deficit? The last time I was here, I talked a lot about cognitive screening and dementia and mild cognitive impairment. As we see elderly patients and this silver tsunami that's coming to us, we're going to see more people with varying levels of cognitive impairment, and it can fly under the radar, so we need to think about that. So perception in this case is very literal. It's just, are we even asking our patients about their hearing, or are we doing any kind of screening, or do we tell them to go and get an audiogram occasionally? E is for education. I've already talked about how education is correlated with health literacy. And so if somebody has low educational accomplishment or attainment, like they didn't get a chance to go to high school, maybe they only finished elementary school, well, that's going to affect their ability to understand and to process and to obtain the information to make medical decisions. So, as we're sizing somebody up, we should be kind of getting a sense of where their education is. Access, that's kind of more on us. It's like, okay, how easy or how difficult am I making it for this patient to access the information that they need? So for an example, I was talking about the language level, the grade level of the documents. If you have things that are written too technically, or sometimes we get things from other sources. The pharmaceutical reps will bring us papers, or we'll pull something off the internet from some patient advocacy site. And if you look at it, it's written at a very high level. It's written at a 12th grade level. And most of you, I bet, have Microsoft Word. If you have a Word document, you know how you can check the spelling and you can check the grammar? Well, under that same tools drop-down menu, you can check grade level. They call it Fleischer-Kincaid reading level. I think in some programs I've seen it called readability statistics. But the thing is that just as easily as you can scan a document for spelling errors, or you can scan a document for grammar mistakes, you can see what the reading level is. And if it's above 6th, if it's a 10th, 11th, 12th, a lot of people are not going to be able to understand it. Probably more than 50% of your patients are not going to get it. And as I mentioned earlier, studies have shown that even doctors, even myself, if I'm in the ER because I have something going on with me, I don't necessarily want the ER doctor to be talking to me as a doctor. Well, we found that this creatinine is doing this, and then look at your sinus rhythm turned into this arrhythmia, and I want to know what is the diagnosis and what do I need to do about it, and which specialist or whatever. Even as a physician, I don't necessarily want a dissertation about my illness. Now once I'm relaxed and I have time to think about it, then maybe I'll do my own research. So think about how accessible your information. Another example, so many of our systems are moving to online computerized things, right? I bet you that some of you, your clinic or your healthcare system has a portal where patients can log on and try to make their appointments or ask questions or get some of their lab results and things like that. Well, again, that's very, very difficult for some people. If you have a younger, 40-something who is educated and they work with computers all day long, they love that stuff. They already are using it. They book all their travel online. They're using online banking. If you have a 75-year-old, probably not so much. A 75-year-old is probably still going to the bank and talks to the teller real time, and if they're making a trip, they call or they go to the travel agent or whatever. I mean, it's a different culture. It's a different expectation. So you have to think, sometimes we make these changes in our office. Oh, it's going to be so much easier. Just let's put this phone tree in, and, if you're calling to make an appointment, press 1. If you're calling to change an existing appointment, press 2, If you have somebody who's hearing impaired, are they going to be able to get through that menu? So we have to think about these things. And then the K is for knowledge. And the K actually applies to us as physicians or as a healthcare system. It's sort of like, what knowledge do we need to get better at this? What changes do we need to make? Should we be assessing our patients with the newest vital sign? Should we be formalizing this Ask Me 3 into our electronic health record? Wow, we're getting all these new patients that are Vietnamese now for some reason. We have all these Vietnamese and they speak Vietnamese. Maybe we need to make some changes in our practice to address the needs of the Vietnamese folks or whatever culture it is. So it's sort of a thing that I think, like I said, all of us are kind of doing it automatically, but if we formalize it, and if you're really interested, I recommend that reference. The other mnemonic is called LEARN. This is a little simpler, and this was originally formulated for cross-cultural medicine. If you're dealing with somebody from a culture that you don't understand, it's good to go through this in your head. So if you're seeing somebody, maybe you're using a translator or interpreter, maybe you're not. Maybe you have to use a family member as an interpreter, which is not ideal, but sometimes that's all we have, right? But if it's a foreign culture, then if you think of the L, means listening, taking an extra time to listen to the patient or listen to the interpreter so that we can kind of understand where are they coming from, what is the nature of their complaint, what are they really concerned about, and try to do this in a non-judgmental and sympathetic manner so that it kind of shows that you're really trying to understand. The E is for explaining and empathizing. So you actually formally explain it. You express it very, very, very clearly. You say, it must be tough for you. You're a Vietnamese immigrant. You're here in America now. You're not speaking English so good. I can understand that, and it must be scary to be at the doctor's office. Something like that. You make a statement that shows that you empathize and you explain that you understand their concerns, and then you kind of try to explain what the problem is in non-medical terms. The A is for acknowledging differences, So, for example, if you're seeing somebody who, in my practice, I see a lot of Mexican-American patients or Mexican immigrants, and they may come in with medicines from Mexico. They love shots in Mexico. Have you ever noticed that? I mean, they'll actually prescribe shots. People learn how to give shots, and they give themselves a shot when they need it. So I'll say, I realize that in Mexico you use these injections a lot, but I prefer to use an oral medicine. We have oral medications here in the U.S. that I think work as good as that injection, and I would be more comfortable doing that. So you kind of acknowledge that there's a difference. You acknowledge that the patient wants this or is used to being treated in that way, and you sort of put it out there, but you say, but this is why I want to recommend differently. And then that's what the R is. You recommend a treatment. You don't just say, okay, here's the prescriptions, and we'll see you in 6 months. You say, this is what I would like to do, and it's because of this, X, Y, and Z, because you want to kind of tell the patient you respect who they are and you respect your differences, and you're just there to advise and to teach, right? If you look up doctor in Oxford, older Oxford dictionary, it says the definition number 1, teacher, somebody who conveys information, teaching. And then the N is for negotiating an agreement, because, like I said, if you're dealing with somebody who's culturally very different from you, they're probably going to go out and they're going to consult their own circle of advisors and say, okay, this American doctor told me to do the X, Y, and Z, but I'm not going to do it because my faith healer or my curandero or my shaman or whatever it is tells me that I'm supposed to do something completely different. So you sort of negotiate and say, this is what I want you to do. Can we do this for the next visit? So it's the LEARN model, and think about it when you're doing cross-cultural type of stuff. As I mentioned on the written materials, please make sure, we have to say we dumb it down a little bit, because if your paperwork says, we want you to get an MRI exam of your brain Please notify us if you have any implantable devices. Call this number to schedule an appointment at your early convenience. And you're giving these instructions. Inform the staff if you're claustrophobic. Those are technical terms, implantable devices. Does everybody know what that means? Pacemakers, not necessarily. Claustrophobia, do they recognize that word? So you should write on your paperwork, it should say, we want you to get this test that scans your brain. Do you have any metal or anything artificial in your body? Please let us know. Do you get worried or nervous in tight spaces like an elevator? So you kind of dumb it down and give them examples, and then they'll understand it better, and it'll actually mean something, this piece of paper that you're using. And use pictures, photographs, multimedia devices as much as possible. We're going to do another case now, and I'll demonstrate a little bit about how to use maybe some charts or graphical things. There has been research on this, and some people assume that, if we have this DVD, but we have this immigrant, farm worker population, they're probably not going to use it, or maybe they don't even have DVDs, or maybe they don't like video. But actually, for a lot of ethnic minorities, video works even more effectively than a written document. People love to watch stuff on their TV, and DVD players are almost ubiquitous now, and people love to hear things, audio. All right, so now Ms. D, I'd like to invite Ms. D. So this is a different patient. This is not the same patient we had before. She's actually a 44-year-old married legal secretary. So she's very educated, very sophisticated. She pretty much comes in every year for routine physicals, and she's been essentially healthy. She does have a family history of diabetes, however. So unfortunately, her labs 6 months ago showed a fasting glucose of 135, and then we brought her back a month later, 5 months ago, and her fasting glucose was still high, 138, and her hemoglobin A1C was 7.9%. So she was referred to diabetic education and told to take diet changes, exercise advice, and so now she's back for follow-up. So we're going to see how it goes with Ms. D here. Well, hello, Ms. D. It's good to see you again. Unfortunately, your diabetic tests, your blood tests show that your sugars keep climbing and your diabetes is getting worse. It's really time to start a medication now. So I want to give you something that's called metformin or glucophage. It's a medicine that we use to control blood sugars, help your body control blood sugars. Maybe you've heard of metformin or glucophage before. It's an insulin sensitizer, and it'll probably help you to lose weight as well.
I can't believe this. I've been really trying to change my diet and reduce my carbs. I haven't had even ice cream in months, and unfortunately, I haven't been able to exercise either. Oh, God, I've been so busy at work, and the weather, the weather has been terrible. Is a medication really necessary? Hasn't metformin been on the market for a while? And is it really the best choice for me?
Yeah, those are good questions, but metformin or glucophage, it's a first-line medication. It's generic, it's inexpensive. All these expert guidelines tell us that we should use it first. It doesn't cause hypoglycemia, and it's well tolerated.
Don't all these medications have side effects? Didn't they just take a medication off the market for liver failure or something like that? I've been so busy at work. I missed 1 or 2 diabetic classes. I feel like there really has not been enough time for the lifestyle changes to work, to really make a difference in my diet and exercise.
Ms. D, it's been 6 months, and you've been to diabetic education. We need to be realistic. With your family history, your numbers going up, your diabetes is getting worse, we just need to start a medication. It's that time. Your renal function is normal. You're not going to have any problems with it. You're not going to have any adverse reactions to the metformin.
Doesn't diabetes take years to kick in, and cause problems? I really would want to try something that's more natural, and I just want to work on my diet and exercise, okay?
By the time that we diagnose diabetes, we know that it's already been present for years. This is not something that happens overnight. They've done studies, and for example, retinopathy is present in a high percentage of patients that have newly diagnosed diabetes. It's time to start the medication.
Okay, so what exactly was my glucose, hemoglobin?
You know, in my line of work, I see people that have bad diabetes. They have to have their legs amputated. They have to get on dialysis because their kidneys fail. They go blind. It's time to take the medication. Here's your prescription.
Well, it doesn't seem that high. You know, I remember someone at a diabetic class was over like 10%. Now, here, isn't there another diet-based approach or nutritional supplement that I can use to control my sugar?
You know, you need to go back to diabetic education, and they're going to tell you how important this medicine is, and I'll answer all your other questions. All right? So, have you ever had an encounter like that? I mean, sometimes we get these patients, right? And what happened in this case is that 2 weeks later, the office got a notification that she was changing doctors. She was done with us, and she was going to go elsewhere, all right? This happens, right? And so let's apply everything that we've learned about health literacy, and we'll do it again, all right? We're going to go through it again. Well, hello, Ms. D. I'm glad to see you back again. Unfortunately, your diabetes is getting worse. You know, I have your lab results here. Your tests are going up, the sugar's getting higher, and so it's really time to start a medication. I want you to take something that's called metformin or glucophage. It'll help you control your sugars. Maybe you've heard of glucophage or metformin before. It's an insulin sensitizer, and it'll probably help you to lose weight as well.
I can't believe this. You know, I've really been trying to change my diet and reduce the carbs. You know, I haven't had ice cream in months. I mean, unfortunately, I haven't been able to really exercise as much as I would like to. You know, I've been just so darn busy at work, and the weather's been terrible. Is a medication really necessary? I mean, hasn't metformin been on the market for a while? And is that really the best choice for me?
You know, I understand. It's really hard when you're trying your best and the diabetes doesn't cooperate, your body doesn't cooperate. But the fact of the matter is that your sugars are getting higher. And we know that when diabetes isn't treated and your sugars are getting higher, you're going to be at more risk for complications. You know that diabetes can cause complications like heart disease, kidney failure, blindness, vascular disease, all kinds of bad things. So I really think that the sooner we start the treatment, the quicker we're going to get control of your sugars, and then we'll be able to help with your sugars, reduce the chances of your having complications. I know that you're concerned about your health. That's why you're here. I'm concerned about your health. We're trying to get you as healthy as possible. And so that's why you're frustrated. I hear that. But we need to move on and get you on a medication. I propose that we start with a low dose of the metformin so you don't have any side effects. And then as you go along, and if you lose weight and you start getting back on your exercise, we may even be able to take you off the metformin.
You mean I could possibly be taken off the metformin? I mean, I've heard something, you know, like with Dr. Oz of talking about the cinnamon and everything like that, and
You know,
it just seems so rushed to me to start a drug right away. You know, I'm worried about the side effects and becoming dependent on it, and I just feel bad. Maybe I didn't take this as serious as I should have in the first place, and now you're telling me I need some type of medication. You see, I have a pretty good commitment, and when I set my mind to do something, I do it. And I just think I need a little bit more time to work on the diet and the exercise.
Right. Well, this is why I'm saying that we need to get control of your sugar, because your hemoglobin A1C has gone up. It's up to 8.8% now. The goal is to be less than 7. Look, 8.8%, that means that your average sugar is about 200. That's your average sugar is 200.
Oh my God.
It's supposed to be less than 150 at the max, and then when you're fasting, it should be less than 100.
Wow, I didn't even realize that. You know, every time I test in the morning, it's usually about 130 to 140.
Yeah, see, that's running too high. And ideally, we want our diet and our exercise and, you know, maybe natural things to help us. But right now, you need a medication, and as I said, we might be able to get you off of it in the future if you lose weight and you get on an exercise program. So I just want to explain what I've talked about and make sure that I made it very clear, okay? So what did I say about your diabetes?
Well, you said that my sugar is continuing to go up, as well as my A1C test is also going up. And right now, my diet and exercise is not really working yet.
Right, okay? So what are we going to do about it?
Well, I'm going to start this medication. What did you say it was? Metformin. And then I'm also going to work on my diet and exercise as well, and hopefully I can get off in the future.
Exactly, all right? So I'm writing a prescription here. I've also written out some written instructions for you to go over what we've talked about, and I really do want you to follow up with diabetic education because they can answer your questions about supplements like cinnamon and other things that you might read about, okay?
Okay.
Do we have a deal?
Thanks a lot, Doc.
All right, thank you. All right, so we did things a little differently there, right? Again, I want to thank Princess Clark for being a good actress here. So, if you notice, I kind of tried to apply that learn thing where, you're listening and you try to clue in, okay, what is it that this person's really, afraid of? And so I try to address the concerns and try to explain it, acknowledge that there's differences, and then we sort of, I recommend a treatment and we kind of negotiate an agreement. It's not always going to go so well, but when you're dealing with a difficult patient like that or somebody who's kind of challenging you, I mean, nowadays, how many people come in with their, internet printout, right, of what's supposed to be best or what their diagnosis is before they've even seen you. So, all right, we want to simplify the message. We don't want, this mess of gobbledygook. We want to try to reach patients, get them the information in a way that they can understand that's appropriate for them so that they can actually do what we ask them to do. So again, the pearls. Edit your written patient education material to adjust to a 6th grade level. And remember, you can use the Microsoft Word grammar tool, the spell check function, and look under readability statistics if you have it on a digital, it has to be in a digital file, obviously. You can't just scan something in that's written on paper. And then you incorporate the teach-back method into your daily practice. It doesn't take a lot of time, and it does wonders for patient understanding and also their satisfaction. How many of us are rated on patient satisfaction now, right? It's becoming more and more common. The big healthcare groups have been doing it for years, but now almost everyone is doing it, and they're doing these clinic encounter surveys, and then that's going to be coming back to us to judge us. And then see about integrating something like the Ask Me 3, which is just, what is my main problem? What do I need to do about it, and why is it important that I do something about it? Because that also helps cement the concept with patients. All right, thank you so much. I'm going to take a break to start looking at your written questions, and then we're going to go over those pre-test, post-test audience response real quick.
All right, thank you so much. That was great. All right, so let's do our post-test question.